Thanks everyone for signing up. It's 12:05, so I think it's time to get going. So we're very excited today to have a real international superstar, Professor James Januzzi Jr. from Harvard Medical School here is going to be discussing the evolution of cardiac biomarker testing. And so I've got the intro. It's quite long, but I think it's worthwhile going through. Jim has worked with many people in Toronto and, really has made a huge impact on biomarkers. And he's currently the Adolf Hutter Professor of Medicine at Harvard Medical School, Director of the Guideline-Directed Heart Failure Medical Therapy Center at Massachusetts General, and the Chief Scientific Officer and C. Michael Gibson Chair at the Baim Institute for Clinical Research. He is just a wonderful clinician, trialist, and educator. And as I mentioned, has really led, I think, sort of optimizing diagnostics and therapeutics for heart disease around CAD and heart failure. And I think you can't pick up any work that has natriuretic peptides and not see his name all over it. He is, in fact, published more than 1,000 publications, 150,000 citations, and is one of the top 1% most cited researchers in the world. And he works with Dennis as the deputy editor at JACC. But I also like this bit of your CV. He's the team physician for the Boston Red Sox baseball club since 2005. So with that, we'll hand it over to Professor Januzzi.
Thanks very much, Dr. Connolly. And yes, in fact, I am one of the team docs for the Red Sox. And in fact, totally fortuitously, today my cufflinks are Boston Red Sox, so a little bit of hometown color here. It's great to see you all, to connect with friends and colleagues, people with whom I trained like Qiming, people with whom I published some of my first papers like Dr. Mo. So it's a real privilege to be joining you to talk about biomarkers. Just by way of disclosures, as Chief Medical Officer at the Baim Institute for Clinical Research, we do a lot of interaction with industry, so it's important to keep that in mind. What I'd like to talk about today is, the role of biomarkers, but what can we say about biomarkers? It's important to emphasize they're a support to clinical judgment. They don't replace clinical judgment, and that's something that Gordon, Mo, and myself tried to make the point way back in the very beginning of this journey. But importantly, they definitely provide useful information in some patients that might not otherwise be obvious at the bedside. And this, I hope, should become clearer and clearer to you all when we start talking about the emerging roles for management of chronic patients in the outpatient setting, as well as early diagnosis of heart failure risk in the people who do not yet even have overt heart failure. So we're going to largely focus on heart failure. We may talk about some other diagnoses in a little bit. This is not a new topic, however, and importantly, it's important to acknowledge those who came before us who really paved the way. Gene Braunwald, back in 1964, 2 years before I was born, wrote an editorial in the American Journal of Medicine speculating that someday the heart would be recognized as an endocrine organ, measuring substances secreted from the heart as a means by which to more accurately diagnose and establish prognosis in heart failure. And indeed, about 20 years later, a Canadian, Adolfo Debold, who's Argentinian, of course, but he was in Montreal, ultimately moved to Ottawa, first described the presence of electron-dense granules in the atria of laboratory animals, and when re-injected, those electron-dense granules induced an intense diuresis and natriuresis. And there are times in medicine when you get to meet your heroes, and although Professor Debold unfortunately passed away not long ago, I was absolutely thrilled to join him for dinner one night. And during the entire dinner, I was just gushing about how, he influenced my career, and without his work, I never would have, really focused on the area of biomarker testing and heart failure. And at a certain point in the dinner, I don't know if any of you knew Professor DeBold. He's a very practical, down to earth guy. He looked at me and he said, "Yeah, that's really great. I'm really glad to hear it. Do you want to go get a drink in the bar, maybe?" He was a really down to earth, great guy, and I really appreciated his work, which focused on these electron dense granules, which ultimately were found to be atrial natriuretic peptide. He called it atrial natriuretic factor, but of course it's a peptide. And it was the first of several peptides that were subsequently identified. Urideltin, which was converted into a pharmaceutical grade therapy called ularitide, which failed in clinical trials, but still potentially has a role for, in particular, inducing diuresis and natriuresis at the kidney level. B-type natriuretic peptide, previously called brain natriuretic peptide, because indeed it was found in brain tissue, but the overwhelming concentrations of BNP are found in myocardium. Everywhere where there is heart muscle, that includes the atrium, the ventricles, the right ventricle, but obviously in highest concentration in the left ventricle because of the muscle mass. D-type natriuretic peptide is found in the venom of the green mamba. And CNP, C-type NP, it's a vasodilating natriuretic peptide secreted by endothelium. And you'll notice that across this entire family of peptides, there's a highly conserved ring structure. The ring is responsible for the biological activities of the natriuretic peptides, which are actually an extremely primitive system in the body. It evolved from deep water fish, actually, as a means by which to regulate osmolarity in fish. But whether you look at the natriuretic peptides in fish, in lower primates, higher primates, dogs, cats, humans, they all have this ring responsible for the biological effects of the peptide. And just by way of summarizing maybe 50 years of research in one slide, the natriuretic family does a number of different things, but importantly, at least in the framing it in the context of heart failure, view the natriuretic peptides as the polar opposite of the renin-angiotensin-aldosterone system. So on the far right, angiotensin 2 stimulates the AT1 receptor, leading to a number of different cascades that ultimately result in vasoconstriction, interstitial and fibrosis with cardiomyocyte dropout, as well as salt and water retention with hypertension. On the other hand, the natriuretic peptide superfamily binds to two different receptors that transduce the effects of generating intracellular cyclic GMP that ultimately, through second messenger processes, counter-regulate the renin-angiotensin-aldosterone system. So although we've taken to thinking of higher concentrations of natriuretic peptides as being a bad thing, in quotes, technically speaking, at least teleologically, it's a good thing. The body is trying to unload itself through vasodilatation, lowering of blood pressure, reductions in cardiac fibrosis and hypertrophy, and of course, stimulation of natriuresis and diuresis. By and large, ANP and BNP bind to the NPRA or NPR1, depending on which group you talk to, whereas CNP binds to NPRB. Both groups of natriuretic peptides are cleared by the clearance receptor, NPRC, as well as by other active mechanisms. And this is important because I'm going to drop some old knowledge here on you, but it's, I think, helpful to understand, particularly given the expanding role of natriuretic peptide testing, that you try to understand a little more deeply about these blood tests than simply that they bind to this receptor and trigger good things, right? So one very important thing to know is that when you measure natriuretic peptides, you're not actually measuring generally the parent compounds. What I mean by this is, in the context of cardiomyocyte stress as one of the triggers for natriuretic peptide release. The cardiomyocyte rapidly upregulates an intracellular precursor peptide called proBNP-108. In normal individuals and in early to moderate stage heart failure, what then happens is proBNP gets cleaved with the release of the N-terminal fragment, NT-proBNP, and the C-terminal fragment, BNP. And I showed you the C-terminal fragment of BNP is here, right? This is, the 32 amino acid peptide that we test for. But it turns out very rapidly after release, what happens is the body begins to degrade BNP through a number of different enzymatic processes. And yet, because the assays that we test BNP for are targeting the ring structure, which I pointed out on the prior slide, is the last thing to be degraded. Therefore, most of the assays that we use for BNP, if you measure in white bars, if you go to quantitative mass spec and look for the intact 32 amino acid BNP, in fact, there's not a whole lot there in circulation. So this means that when you look at the spectrum, most people have a mixture of circulating natriuretic peptide fragments. Why this is important, in one part, speaks to the fact that each fragment has a different biological activity. And people like John Burnett at the Mayo Clinic has really focused on trying to understand how you can take different fragments from the different natriuretic peptides, which are generated through enzymatic degradation by enzymes like neprilysin, and splicing them together. So, for example, ANP, certain fragments of ANP cause a lot of natriuresis, but not very much blood pressure lowering. Some fragments of BNP cause a lot of blood pressure lowering, but not a lot of natriuresis. So by fusing them together, one could theoretically generate a bespoke natriuretic peptide that could give you all of the biological benefits of the peptide without perhaps too much hypotension or too much diuresis. So it's a really interesting question looking into the future as to whether we'll see some of these designer peptides coming. John has done a lot of work in this space, really focusing on trying to move that space forward. So that's on the BNP side. The other piece of knowledge that I think is important for you to know is that when you look at the production of the natriuretic peptides, I've already mentioned this cascade of proBNP cleaved into BNP and NT-pro. And that's what we thought was going on back in the sort of the early to mid 2000s when Dr. Mo and I were doing our first studies with the natriuretic peptides. But it turns out that as a person develops more advanced forms of heart failure, more and more proBNP-108 is released without the cleave, right? So you get uncleaved proBNP-1 to 108. Now, in a perfect world, that wouldn't matter, right? And the perfect world being that this ring structure is still present. So theoretically, the person would still get the benefits of natriuretic peptide release. But it turns out actually that proBNP-1 to 108 does not generate anywhere near as much receptor binding or generation of cyclic GMP. So what this means is as heart failure advances, and more of the proBNP-108 is produced, the body recognizes it's not getting the benefits of BNP stimulation of the NPRA receptor, and so it starts churning out more and more natriuretic peptide in an effort to overcome this deficit, this handicap. That's why, as we see patients with chronic heart failure, their natriuretic peptide values, among other reasons, goes up, even if their filling pressures aren't very different. In part, it speaks to this dysregulation of proBNP-108. This challenge, to me, also represents another potentially druggable target. The reason why I say this is in normal physiology, if you pressure load the heart, either experimentally or in humans, what happens is that there's N-terminal glycosylation on the proBNP peptide that gets removed in the setting of volume overload, which allows furin, which gets upregulated, to come in and cleave, right? So that's the normal physiology. But in heart failure, particularly chronic heart failure, this is lost. And so this process of deglycosylation in the N-terminal portion of the peptide and upregulation of furin activity is lost. And so although in normal situations, you normally liberate NT-proBNP and BNP, in chronic states, you lose that ability. And so the N-terminal fragment to total proBNP ratio goes back towards 1. And in that, you lose the stimulation of the NPRA receptor for that reason. And so many of us have been thinking a lot about how one might harness the ability to restore normal deglycosylation of the amino terminal stretch of the proBNP peptide. And it turns out there are a number of ways by which this may occur in a secondary fashion. For example, use of sacubitril valsartan has been shown to alter N-terminal glycosylation patterns, which may in part explain why there's an increase, a burst of endogenous natriuretic peptide release in people who take sacubitril valsartan. So this is not related to blocking the breakdown of ANP and BNP, but actually enhancing the processing of proBNP 1 to 108 into the free BNP that generates the benefit. So it's important to recognize there are a lot of caveats to what we are measuring when we measure these peptides. Now, importantly, and I'm just going to go back a slide or two, importantly, when we measure BNP in somebody with a lot of this proBNP 108 circulating, the antibodies bind to the ring structure. If we measure NT-proBNP, it binds to the amino terminal portion. So it's all good. I mean, the assays are still telling us what the concentration of these peptides may be. But like I said, there's a caveat that you need to understand. It's not just pure NT-proBNP that you're measuring or just pure BNP, but a mixture of all sorts of different fragments. That somewhat extended introduction notwithstanding, the natriuretic peptides have a pole position from a biomarker perspective in heart failure clinical practice guidelines. They do in the ACC-AHA, HFSA guidelines. They do in the Canadian guidelines. They do in the European guidelines. And I'll touch on many of these different applications, not really dwelling on the things that we've known about for many years, for example, about diagnosis, but really talking more about the more edgy applications. And that really is where the universal definition of heart failure comes in. I actually really quite like the universal definition because although it provides helpful context for thinking about people with symptomatic heart failure, it also brings into play the role of thinking about prevention. People who are at risk for heart failure and people who have cardiovascular dysfunction without overt symptoms. And biomarkers, as you'll see in a moment, play an important role. So, for example, people with stage A heart failure, somebody like me, I've got multi-drug hypertension, for example. These are people at high risk for heart failure. And by definition, a person with stage A heart failure does not have abnormal biomarker measures, whereas stage B heart failure is now defined by the presence of structural heart disease. So if Qiming does an echo on someone and sees an elevated E over E prime or an enlarged left atrial volume, that would qualify them as having stage B heart failure. But there are people whose cardiac ultrasounds are completely normal, and yet their natriuretic peptides or high sensitivity troponin are elevated. Now, back when Dr. Mo and I first started working with natriuretic peptides, it used to drive people crazy when we'd see someone who had no obvious structural heart disease, no obvious symptoms, but their NT-pro was elevated. And people were really confused as to what this really meant. Well, we now know, and it's now accepted and in fact embedded in clinical practice guidelines, that biomarkers really do and should play an important role with respect to detection of the earliest molecular risk for structural heart disease and heart failure risk, even before structural changes may occur. So it's another way of saying that suspension of disbelief is very important in this setting because it's well recognized that once a natriuretic peptide or high sensitivity troponin is elevated, risk for heart failure onset is significant. For that reason, the universal definition altered its definition of stage B heart failure, including the natriuretic peptides. So we asked the question, Reza Mohebi from my group asked the question, what is the impact of this change? In other words, we're now adding natriuretic peptides to this to define the universal definition of heart failure stage B. So we went to a pooled analysis from the Framingham, CHS, and MESA to look at the impact. And what we found was that by adding natriuretic peptides to define stage B, there was a more than doubling in the proportion of people who are now defined as having stage B. So it reduced stage A and increased stage B. Now, again, clinicians might look at that and say, all right, here we go again. The biomarker people are, having fun again. But what does this really mean? Well, a few important things. The first is that because women typically have higher natriuretic peptide values, this is because androgens, which men have more of, suppress the natriuretic peptide gene. So women typically have higher natriuretic peptide values. So by adding natriuretic peptides to stage B, there was a substantially larger shift among women into stage B. And furthermore, somewhat unexpectedly in a sense, and I'll explain why, there was also a significant shift from a racial and demographic perspective, with more Hispanic individuals and more Black individuals shifted into stage B. Now, you might say, well, that makes sense because of social drivers of health. Minoritized individuals might have a higher risk for stage B heart failure, and that is true. The reason why it was a little surprising to me is because Black individuals particularly have a genetic predisposition towards lower natriuretic peptides. So unlike women, where the shift to more women in stage B wasn't so surprising, it was a little surprising to me to see that that more Black men were shifted into stage B, which really sort of says that our genes are not necessarily our destiny, and really social drivers may play a greater role with respect to predicting the shift towards stage B heart failure. But really, where the money meets the road is whether this shift and increase in stage B would have an impact on our ability to predict transition to symptomatic heart failure. On the right panel is the old ACC/AHA guidelines, which did not include biomarkers in stage B. On the left is the universal definition of heart failure, now including biomarkers. And what you can appreciate is the Kaplan-Meier curves look basically identical, which means that the denominator increased, but so did the numerator, suggesting that the use of biomarkers to define stage B in a fully adjusted analysis, by the way, remained an extremely robust way to predict the onset of heart failure in the community, particularly in people with risk factors on the clinical side of things. So why might that be? Why might looking at somebody with a completely normal echo, for example, would an elevated natriuretic peptide predict risk? Well, this was a paper I handled back years ago when I worked at Jack Heart Failure that I still bring up because I think it really tells an important story, which is researchers took people with a normal cardiac MRI at baseline and with an elevated B-type natriuretic peptide. And what they found was that from baseline to 3 years, those with an elevated B-type natriuretic peptide had a rise in their left ventricular mass index compared to people who had a relatively normal value or those with a very low value, where there was actually regression in LVMI. So it just goes back to that slide I showed where we're talking about, and Dr. Verma has joined us. Subodh, I hope your surgery went well. It's great to see you.
Thank you, Jim. Thank you so much for doing this. And thank you, Kim, for stepping in there. So please continue. I'm right here.
Absolutely. Thanks so much, Subodh. What it says again is we are able, using these really inexpensive, widely available tools, to identify a molecular signal even before imaging can tell you that a person has had increased volume load or stress on the cardiomyocytes. This probably, in the last 10 years has been where I'd say one of the biggest shifts in thinking has occurred. So an abnormal natriuretic peptide in the absence of symptoms has gone from being an annoyance, from being a frustration for clinicians, to actually now being guideline embedded, not just in the ACC/AHA guidelines where it has a 2A indication, but it actually has a class 1, you should do it, in the American Diabetes Association guidelines. And the reason why is that, yes, I realize that for us clinicians, it's a big thing to get your arms around, to have to test a natriuretic peptide in every single individual that you're looking at. But we're not even saying that in the heart failure guidelines. But as was pointed out in the ADA guidelines, there are populations where you can really enhance the discrimination of testing. Individuals with diabetes represent, I would say, the pinnacle of clinical risk for incident heart failure. I mean, we could argue this, right? I mean, left ventricular hypertrophy is another, of course, but when you look at the cardio-kidney metabolic overlap, whether you talk about people who've got CKD with albuminuria, diabetes, these are people who have extraordinarily high risk for incident heart failure, but not everyone has that risk in this population. In Canvas and in Credence, we've done a lot of work looking at biomarker testing. And, a baseline natriuretic peptide, I hate dichotomizing, but clinically speaking, it makes it easier to understand. A baseline NT-proBNP of 125, which is considerably lower than the cuts that we use in acute heart failure, was found in about 39% of people in Canvas, for example. So not at all unusual by any stretch among people with diabetes. And although NT-proBNP in a fully adjusted model predicted pretty much every endpoint that was examined in this study, the ones that really jumped out were hospitalization for heart failure. And I'll remind you that only 13% of people in Canvas had an overt diagnosis of heart failure at baseline, as well as progression of chronic kidney disease. Gee, wouldn't it be great if we had medicines that treated diabetes, chronic kidney disease, and heart failure, right? I mean, you can see where I'm heading here. We actually do, which is one of the reasons why the American Diabetes Association has thrown their weight behind routine and sequential tests for natriuretic peptides. This is based on, for example, data from the ELIXA study, where people, even without a history of heart failure, and of course those with, when measured sequentially over time, there was a rise seen in natriuretic peptides occurring well before the incident event. So it really speaks to the importance of not only a single cross-sectional measurement, but serial measurements. So I was fortunate to work side by side with the president of ADA 3 years ago now, when we published our consensus document in Diabetes Care, which has now been incorporated into their standards, which is their yearly update of guidelines, where among those with diabetes, whether it's type 1 or type 2, besides routine assessment for signs and symptoms of heart failure, it is now recommended to measure a natriuretic peptide or high sensitivity troponin with the goal of identifying individuals at highest risk for incident heart failure. Now, you might say, whoa, 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 there are 500 million people in this world with diabetes. We're not going to measure natriuretic peptides in everyone. And that's absolutely true. However, in this consensus document and in the standards of care, we give, I would say, pragmatic, useful guidance as to who would be best for testing. People with long-standing disease, people with uncontrolled hemoglobin A1C, people with comorbidities enhancing their likelihood for heart failure onset, including chronic kidney disease with albuminuria, hypertension with left ventricular hypertrophy, This is not rocket science. This is clinical cardiology 101. And through the recognition of enhanced risk, we have a full armamentarium of therapies that can reduce heart failure risk in such individuals. ACE inhibitors, ARBs, nonsteroidal mineralocorticoid receptor antagonists, SGLT2 inhibitors, GLP-1 receptor agonists. We literally have a tool belt full of therapies where people at enhanced risk for heart failure could be well treated. And indeed, this is something that I feel extraordinarily passionate about, and really thrilled that Rodica Papbusui from the ADA feels similarly. And so we will continue beating this drum to really continue making the point that there's a lot of opportunity beyond, of course, the already embedded roles of natriuretic peptides for symptomatic heart failure, right? So you work with a pioneer in this space, Dr. Gordon Moe, who did some of the earliest work looking at the role of natriuretic peptides for diagnosis in acute dyspnea. Now, I'm not going to talk too much. In fact, I'm not going to talk at all about this because it's really so 2005, right? To talk about the diagnostic role of natriuretic peptides. I think we've kind of overcome this argumentation that it's not just a need, not just a want, but a need to help enhance clinical judgment. This is the Mass General Hospital way of practice, which is, well, Bob, it looks like a paper cut, but just to be sure, let's get an echo, right? But in truth, heart failure is not an easy diagnosis to make. And whether we look at work that Gordon did in a randomized fashion, work that Brian Steinhardt did, looking at the role of clinical judgment and the potential value of natriuretic peptides. What we've found over the years is that, by and large, heart failure is frequently judged with a great amount of uncertainty, and those individuals judged with uncertainty have worse prognosis and a higher rehospitalization rate, a more diffuse workup strategy. And this is really where the guidelines, appropriately on the basis of Gordon's work and others, call out the value of natriuretic peptides for diagnosis when the diagnosis is uncertain. But importantly, having a baseline value is now useful for another application, which is an emerging application, but one that's gaining momentum. And that's for using natriuretic peptides to support pre-discharge risk assessment and clinical decision making. In a world with finite resources, this probably would not be a role that we'd see natriuretic peptides used much for, because we can just keep someone in the hospital for 2 weeks, diurese them, and if they get hospitalized, rehospitalized, so be it. But at least here south of the border, and believe me, I sort of consider Massachusetts a part of Canada for many reasons, as you probably can understand why these days. But south of the border here, if somebody gets hospitalized, we pay a penalty. Furthermore, there's a lot of pressure to get people efficiently out of the hospital. And so for this reason, the use of natriuretic peptides as a tool by which to judge hospital discharge candidacy has grown. This is on the basis of the fact that in the acute setting, there are a lot of triggers for natriuretic peptide release. It's not just volume overload, but in the acute setting where congestion is a very important driver of natriuretic peptide release, it makes sense that the pre-hospital or the admission NT-proBNP at the time of presentation is largely driven by congestion. We know this because in studies looking at discharge natriuretic peptide values compared to the baseline hospitalization levels, the discharge value is a more prognostic tool for predicting who's going to re-present within 6 months. So whether it's the pre-discharge value or a 30% or greater reduction during hospitalization, these are the ways to identify the patients at lowest risk. Just very quickly, why a pre-discharge change of 30%? That's really just the biological variation of the natriuretic peptide. All that's basically saying is that whatever caused it to rise has now been taken away. And so by transitive properties, congestion being the most potent trigger for natriuretic peptide release in the acute setting, it offers reassurance. that one has done one's job and has adequately decongested and started GDMT in eligible patients. So for this reason, the guidelines now embed, here in the United States at least, the recommendation of a pre-discharge natriuretic peptide to help recognize those individuals who have a reassuring reduction in risk, particularly looking for that 30% reduction. The other reason to have a pre-discharge value is because more and more we're utilizing natriuretic peptides to help enhance the outpatient side. So this is the Zakim Bridge here in Boston. It was built around the time that Chi-Ming and I were fellows together here in Boston, part of the Big Dig. And the changes in heart failure delivery systems in the United States has really been dazzling and has been accelerated with the pandemic, where greater urgency to incorporate a number of different means by which to enhance outpatient heart failure care have been put in play. I mean, to be sure, nationally, post-discharge heart failure care is see your doctor, good luck. But that's changing through a number of different programs, including home hospital use, post-discharge programs, GDMT clinics like the one I run, as well as the incorporation of virtual care. So the hospital at home is a means by which we can actually literally set up urgent and emergent care, either post-discharge or to abort or to terminate a decompensation and prevent hospitalization. So it's good both for upstream prevention and post-discharge care. We can do pretty much everything in the home. The one thing we can't do are biomarkers unless a person brings like an Abbott iStat, a professional use device into the home. Furthermore, virtual care is another big advance. We utilize this very heavily in our GDMT clinic to help titrate individuals virtually without the need for an in-person visit. And certainly virtual care, I think, is here to stay. So how might we fit biomarker testing into that context, whether it's the home hospital or virtual care? Well, the first is to think about the role for risk monitoring. These are not new data, but they tell a story that I think is important. So in adjusted analyses in the guided study, after 3 months of medical intensification, people who got below an NT-proBNP of 1,000, so now we're talking much lower values. These are ambulatory outpatients now in the outpatient setting without decompensation to 3 months. Those who achieved an NT-proBNP below 1,000 subsequently, so the T0 on the x-axis is 3 months after med titration. The people who achieved a lower NT-proBNP at that time point, everyone was above prior to this, had better prognosis, whether we talk about a 66% reduction in mortality or 74% reduction in heart failure hospitalization and cardiovascular death. So why might that be? Well, unlike in the acute setting, where congestion is the driver, in the outpatient ambulatory setting, I already sort of hinted at it, when we talked about the role for prognosticating heart failure onset. Natriuretic peptide concentrations are quite strongly associated with cardiac structure and function. We showed this in the guided study, where the achieved NT-proBNP at 1 year was strongly associated with reverse cardiac remodeling in those with reduced ejection fraction. Now, this is on the basis of cross-sectional measurements. What about serial measurements? Now we're talking about measuring every few months in the outpatient setting. These are data we just published not long ago. The cloud of dots are individual NT-proBNP measurements. And in people with reduced EF heart failure, although the baseline value was associated with a high risk for CV death and heart failure hospitalization, by adding serial measurements, this substantially increased the predictive ability. The blue curve are people who had a cardiovascular event. The red curve are people who did not. The event happens on the far right of the x-axis. This is a time to event, essentially. And the two things you should recognize are, number one, people with an event had higher values that ultimately rose over time, well ahead of the event, whereas those people without had a lower value. If you integrate the area under the curve, if you will, and look at all those serial measurements and incorporate, perhaps using AI, the ability to identify trajectories of natriuretic peptides, you can more accurately predict change in ejection fraction as well as change in health status, how patients are feeling, in addition to predicting hospitalization or death events. Furthermore, having these measurements also helps to support decision making about therapeutic interventions. And I bring to your attention the STRONG-HF study, right? This is an outpatient intensified heart failure GDMT study versus usual care. The usual care arm essentially was good luck. I hope you make it to 6 months without a rehospitalization, essentially, versus rapid titration of GDMT. And you are all, I'm sure, aware that the STRONG-HF trial really was supportive of more decongestion, better health status, and fewer events among those individuals randomized to receive high-intensity treatment. What you may not be aware is that NT-proBNP actually played an important role in STRONG-HF in the sense that NT-proBNP increases were used as a means by which to slow down GDMT titration and either intensification or reintroduction of diuretic therapy. But through this use of natriuretic peptide testing, individuals, regardless of a high or low value for NT-proBNP, had relatively similar value from intensified care, although I would draw your attention to the fact that higher NT-proBNP was associated, at least visually, with a lower hazard ratio from intensified therapy, really suggesting that closer follow-up of individuals with biomarkers in the study provided not just a safety signal, but an efficacy signal as well. Indeed, when you look at the safety indicators in STRONG-HF, natriuretic peptides, potassium, and kidney function accounted for nearly 3/4 of the indicators for how clinicians should be making decisions regarding rapid and intensified outpatient administration. And reassuringly, this is very much in line with what our American College of Cardiology expert consensus decision pathway document recommends, which is essentially matching measures of natriuretic peptide at each step of rapid intensification and then into the stabilization phase for chronic heart failure management. The problem, of course, is, well, how in the world are we going to do this, right? You know, the problem is that lab access is probably the biggest challenge for getting biomarker testing to our patients. And I'm not just talking about natriuretic peptides, I'm talking about potassium, kidney function, or other lab measurements. And indeed, this unresolved burden for lab testing is really, I would say, what limits our unfettered ability to do hospital at home as well as virtual care in a most efficient manner. Fortunately, that hopefully that barrier will be removed, because home testing for natriuretic peptides, and Gordon, who would have ever guessed back in the early 2000s when we started measuring NT-pro, we'd actually be able to measure it off a finger stick in the home. But home testing for NT-proBNP, electrolytes, kidney function is on the very near horizon, with a device that works off of 30 microliters of capillary fingerstick blood, pairs via Bluetooth to a smartphone, and allows clinicians to monitor their patients' lab testing remotely. So this has obvious applications, not just in terms of heart failure, but also cardio-oncology, CKD monitoring, monitoring of therapies like myosin inhibitors. The clinical trial applications alone are substantial, as well as the adaptability for other tests. I mentioned myosin inhibitors. This is one of our more recent papers just showing how one could conceptually monitor a patient being treated with aficamten, for example, where the early delta in NT-proBNP in sequential testing was the single strongest predictor of the improvement in peak VO2. In mediation analyses, the early dive in NT-proBNP explained literally the entire impact of AFI on the peak VO2. So as a clinician monitoring your patient being treated with these therapies is one means by which to keep an eye on the patient starting a potentially potent and theoretically risky drug, right? Now, of course, all of these positives, it's important for me to emphasize that natriuretic peptides or even single biomarkers can't do everything, right? So this slide was given to me by Mike Picard many years ago. Mike was our mentor, Chi Ming and I, in the Echo Lab, where in the American Journal of Veterinary Research, and by the way, you can measure, if you bring your dog or cat to the vet, they can and often do measure BNP as a means by which to identify heart failure. But at least in this clinical trial, it was not associated with BNP, with arrhythmogenic right ventricular cardiomyopathy. So biomarkers, it's not a panacea. And that really gets to the issue of what's next. And we've really squeezed a lot of the juice out of single biomarker tests like a colorimetric ELISA for NT-pro all those years ago. But that's where newer markers, incorporation of multiple markers through proteomics, multi-marker panels, machine learning is really the future. I use the example of troponin. Troponin T, a little bit of sort of cocktail party trivia, was actually discovered at Mass General Hospital by Hugo Katos, who was working at MGH in the late 1980s. And of course, all of you know, because you've been testing high sensitivity troponin for years before us, that with high sensitivity assays, you can detect myocardial injury in a broad range of people, even those who don't have obvious acute ischemic heart disease. And this is predicated on the fact that we know that troponin is found in two places in the cardiomyocyte. It's obviously found in the contractile apparatus, but it's also found in the cytosol. And in the setting of myocardial injury, that's one paradigm, the cytosolic troponin is spilled first, and the contractile apparatus is spilled second. But this paradigm of injury leading to cytosolic troponin release followed by sarcomeric release is about to change. And what I mean by that is that it's now recognized that there are other means by which the cardiomyocytes may release troponin. Exosomes are one means by which cells communicate with each other. These microvesicles that bud off of the cell membrane contain cytosol. And to the extent that 3 to 5% of troponin is found in the cytosol, we did a study where we labeled the troponin within exosomes. You may or may not be able to see the little red dots within the exosome. That's the yellow blob. But those are individual troponin molecules, actually. So we began to hypothesize that troponin release from the cardiomyocyte might not necessarily only be from injury and cell death, but also be related to exosomal release. And furthermore, that it might vary depending on whether it's physiological, associated with chronic stress, acute strain, or acute necrosis. So we collected samples on people with a broad range of different diagnoses and isolated exosomes as well as the non-exosomal troponin fraction. And what we found was this dramatic finding, which is that the majority of troponin in normals and people after exercise consists of exosomal troponin and not related to cardiomyocyte injury and cell death. Whereas, of course, people with myocardial infarction, most, if not all, of the troponin was not exosomal, which makes perfect sense, right? So this really opens the door to understand, for example, chronic heart failure. A portion of it is exosomal, most of it is not. Hypertrophic cardiomyopathy, same point. How does that troponin express cardiomyocyte strain? And it helps us to understand these results, for example. In the PROVE-HF study, a trial where patients were treated with sacubitril valsartan, we were able to show that people that had the greatest reduction in NT-proBNP, The greatest reductions in high sensitivity troponin had the largest reverse cardiac remodeling. So it suggests that you can harness a different application for already existing markers to potentially enhance the clinical information you gain from natriuretic peptides. And of course, with multiomics and machine learning, that blows wide open when you start measuring literally thousands of potential data inputs like protein biomarkers. So just quickly in the last minute or two, I'll give you some examples of what we've done there. And Qiming, this is where AI comes in. So we've done a lot of work with multiple different omics inputs, including proteomics, never forgetting clinical variables being important, together in an AI ML model, linking it up to specific outcomes, and then generating potentially clinically useful panels. So this is one that we generated utilizing machine learning, using AI to generate a panel with multiple biomarkers and several clinical inputs to generate a diagnostic for obstructive coronary disease with an area under the curve validated of 0.87 that not only was highly sensitive and specific for identifying obstruction with good positive and negative predictive value, but it actually also had a linear association with the degree of coronary obstruction. We've now developed multiple panels utilizing this modified approach using AI ML with multiple markers, frequently combining markers that we measure in other studies like the natriuretic peptides for various cardiorenal diagnoses, the most recent of which is a study that hopefully will be accepted imminently. It's currently under second review now, where we took the Credence and Canvas trials and through, again, multiple omics, identified several biomarkers known to many of you, mixed them together with clinical variables to develop a really wildly prognostic panel to predict progression of CKD and heart failure onset in the higher risk Credence patients, again, people with diabetes with CKD, and the lower risk Canvas population of individuals with higher risk type 2 diabetes with, when you look at high risk hazard ratios, a hazard ratio approaching 7 is nothing to put your nose up to. So that's really, to me, where the next future will be, which is taking established markers, emerging markers, and utilizing AI techniques to generate these panels. So in conclusion, a true honor and a joy to be connecting with you all. From the earliest identifications of markers harnessed for clinical use, Gordon, you and I, we were there right in the beginning. There's been slow but accelerating evolution towards a better understanding of the broad value that these markers may bring. So diagnosis was where we started. Prognosis was kind of a yawn for a while, but now we're starting to understand how one can fit the prognostic tie-in to better identify risk and prevent heart failure onset. And of course, opening up areas where such testing is not yet available, like home use, as well as in machine learning leverage multi-marker panels. But I really would say, the era of the natriuretic peptides has been a lot of fun, but it's time to move on and really think about how other markers can move in, and we can choose them as the right marker, right? So thinking about what the future will be. So I'll stop there. Thank you so much for the opportunity to come and speak.